Hi, this is Michael Altos. We're continuing our discussion of physiology of blood, and this is recording part 9. We're continuing our discussion of risks of blood product transfusion. We're talking about immunologically mediated risks, and we're on to the third category, which is white blood cell related transfusion reactions. The first is a febrile non-hemolytic transfusion reaction. This is actually a pretty common reaction, occurring in 0.03 but up to 2% of transfusions. This happens when the recipient has antibodies to proteins not on the red blood cells, but on the white blood cells, on the leukocytes in the donor. They can develop fever or chills, nausea, respiratory distress, anxiety, headache, myalgias, cough, and this can occur within 4 hours of transfusion. It sounds a lot like an acute hemolytic transfusion reaction, but it's much less dangerous, and so we really want to be able to distinguish them because the treatment here is really just Tylenol, acetaminophen. The way we distinguish it is by doing that direct Coombs test, which we showed before. If it's negative, that tells us that there isn't any immune-mediated hemolysis going on. We have a non-hemolytic reaction. If we can use leukocyte-reduced products, we'll have many fewer white blood cells and a whole lot less donor proteins to have a reaction against. The next reaction would be a transfusion-related acute lung injury, commonly called Trolley. This occurs in 1 in about every 1 to 5,000 patients. These patients have non-cardiogenic pulmonary edema with acute bilateral infiltrates and hypoxia. There are a few qualifications or criteria in order to diagnose Trolley. The first is a PF ratio, that is a ratio of PaO2 to FiO2 of less than 300, or a pulse ox saturation of less than 90% on room air. We also want to make sure they don't have any left atrial hypertension or volume overload, because that could be a different cause of infiltrates in the lungs. And we see this most commonly with platelets and FFP, although it can happen with red blood cells less commonly. Trolley is the leading cause of transfusion-related mortality, 5 to 25%, and it accounts for 40% of the U.S. transfusion-related fatalities. Why does Trolley cause such a severe injury? Well, there are some hypotheses. One is that there are activated neutrophils that are being sequestered in the lung. These donor antibodies complex with antigens on the white blood cells. In fact, for this reason, some suggest that we should avoid having female donors if there's any chance that they may have been pregnant because of the increased risk of alloantibodies. There's also what they call the two-hit model, the idea that the patient is already sick and they're in some sort of pro-inflammatory state. This primes their neutrophils and gets them ready to attack. And then the reactive lipids that are in stored blood products activate the neutrophils. Either way, other symptoms that we may see include dyspnea, fever and chills, pulmonary edema, and as we said, those bilateral infiltrates occurring shortly after transfusion. The treatment, unfortunately, is just supportive. Put them on the ventilator, manage their fluids carefully, but we can try to prevent Trolley with leukocyte reduction, and again, avoiding patients with high risk of alloimmunization, particularly female donors with any possibility of having been pregnant. Graft versus host disease is quite rare. In this case, the patient's being attacked by lymphocytes from the donor. And so we have an immune response of the graft, which is the transfusion product, against the host, which is the recipient. This is really a risk in immunocompromised patients, like those who've had a transplant of stem cells or bone marrow, patients who have certain malignancies like multiple myeloma, and maybe in solid organ transplant patients as well. We also see this in cases where the donors are related. This is most common with red cells or platelets, much more commonly than with FFP. Symptoms don't occur right away, but within the first few weeks of transfusion, patients develop a fever, rash, diarrhea, leading to liver dysfunction, eventually pancytopenia with greater than a 90% mortality if it occurs. The best way to prevent this is with irradiation in order to inactivate those donor lymphocytes. TRIM, or transfusion-related immunomodulation, occurs in probably almost 100% of donations. The idea is that the patient's immune responsiveness actually is altered as a result of a transfusion. This may be due to white blood cells being transfused or other immune mediators. There's a two-insult theory which says that there's a pre-existing trauma or illness as the first insult. This was first noticed when we observed that patients who got transfusions had a decreased rate of transplant rejection, their Crohn's disease seemed to improve, and they had a decreased risk of spontaneous abortion, all suggesting that the recipient's immune response had been turned down in some way. However, turning down the immune response has some serious dangers. We see increased mortality, especially in patients who have malignancy, who have infections, and a more rapid progression of HIV and AIDS. A good example of why we should avoid transfusing patients if it's not definitely indicated. Transfusion-induced inflammatory response is based on the idea that some bioactive substances accumulate during blood storage. We already said before that red blood cell age correlates with multi-organ system failure and mortality in ICU patients. And there is this notion that shorter shelf times may be appropriate for the sickest patients, although once again, the data is not conclusive. Finally, let's talk about a few other non-infectious risks. When patients receive massive transfusion, they have risk for hypothermia, which can lead to coagulopathy, dysrhythmias, acidosis, and which increases oxygen consumption. TACO, transfusion-associated cardiac overload, is basically fluid overload, which can lead to pulmonary edema. The dilutional coagulopathy, if you don't keep up with your FFP and your platelets, leading to low levels of various coagulation products. Transfusion of many units of blood will decrease the 2,3-DPG and shift your oxygen hemoglobin curve to the left, leading to less oxygen delivery at the tissues. You may see acidosis, whether it's lactic acidosis or excess CO2 or citrate. Hyperkalemia, especially at high infusion rates. Citrate intoxication can lead to hypocalcemia, hypomagnesemia, and this is actually most common with FFP. And iron overload, especially in patients who have chronic ongoing red blood cell transfusion. Remember that there are microaggregates that occur in these stored blood products, and so everything should be given through a standard filter, which is 170 microns, and that will filter out the large aggregates. The micropore filter, which is the 40 micron filter, probably is not indicated for most transfusions unless you are in the cardiopulmonary bypass circuit. And what should we use to dilute our blood products? Well, usually we use normal saline. But actually, lactated ringers is acceptable as well. Some of you may be taught not to use lactated ringers because of the presence of calcium, but it's at such a low concentration that it's unlikely to cause any significant harm. This chart summarizes everything we've discussed and may be helpful for you to review, and it's reproduced in the notes as well. We will stop here. As always, please contact me with any questions about the material.